Hi, today I thought that we will talk a little bit about data and the way the data is shaping the provision of healthcare. Now, the practice of medicine has changed a lot from the times that we were learning this. Changed in some ways, some things have been retained, some things have changed dramatically. And if you look at the evolution of medicine over a period of time, we are in a state of a much rapid or faster evolution, dynamic changes in the practice of medicine. That is aided by the ability to obtain, critically evaluate, assimilate a lot of information as the internet has opened up, as the process of digitalization, technology has opened up huge possibilities. Now, underpinning all these changes that have occurred in medicine and that translate to patient care, population health care, patient care, individual patient care, is the use of data. And that is sort of recognized when we describe the practice of what we call as modern medicine as evidence-based medicine. And it's a transition that sort of took greater strength during the 2000s, early 2000s onwards, as clinical epidemiology and the synthesis of data into clinical care became more of a routine practice. Not across all sectors, not in all disciplines, but it was increasingly recognized that data has an important role to play, that the practice of medicine is not only a skill-based, an art, a skill-based practice or an art of practice, an art that then implies that it's something that you build intuitively over a period of time. And what was brought in was that data and evidence have an important part to play in this whole delivery of healthcare. Now, as data came in, there were several other things that came. We then had to develop the ability to look at data critically and to understand the data. To understand it from the perspective of what in that data is reliable, what is valid, what can be taken, what can be applied, what looks fishy, what is probably not valid in our settings. So the look of data, looking at it, interpreting it, not just taking it as it is, but then thinking, how do you apply this data? And once you start applying, then you have to start evaluating. Then you have to start thinking about how do you evaluate? How do you see whether it's working properly? How do you look at what's working properly? How do you refine the whole system? So a lot of functionality with data came into the whole picture. And it has led in different ways. It's led to an improved understanding of outcomes. It's led to an improved understanding of risk factors. It's led to an improved understanding of algorithms that can be used for decision making. It's led to the development of scores that can be applied to identify people who are at risk at an early stage, to identify severity of conditions. So we found out different ways to convert qualitative information into quantitative information that gives numbers. And to then use those numbers to generate how we would like to treat people. It's led to the proliferation, I can say, of a lot of clinical practice guidelines. Proliferation of clinical practice points, using algorithms, using risk scores, to say that, well, if the score is so much, or if this is A is there, then we need to consider B, and then to build up a pathway to an optimal result. And again, underpinning that whole process is the data that we collate or we collect from the individual patient. Now this data is then shared, the scores are shared, the algorithms are shared, the whole process of development of these algorithms and scores are shared. We look at the process of what happens when we are applying this, we look at outcomes, we share that information, and so we have a whole set of a new dimension that comes in. It's not exactly a new dimension, but it's something that has sort of burst out in recent years. The dimension of publishing and sharing these results. From the times when we were students, when we had, let's say, maybe hundreds of journals, we now have probably 10,000s of journals. And so there's a whole set of information coming from different areas. There's an information overload, and all of which aim to share what they find using different bits of practices, using different bits of information. So now we have a lot of data. We have a lot of data on a lot of material. And our practice of medicine is based on this data. The question then is, two important questions that come up is, how valid or how reliable are the data that we collect? And how valid and reliable is the process of sharing of this data? When I say that it is published, let it be in a high index journal, any journal with a high impact factor. Let it be in a journal without or with a low impact factor, an index journal or a non-index journal. When I say that it is published, what does that mean? How do we translate that into practice, into clinical practice? So these two things have become increasingly important in the delivery of healthcare: the use of data, the generation of data, the collection and collation of data, the analysis of data to make meaningful information, and the sharing of that meaningful information. It's become important because there is a whole set of things, a whole set of information that is coming out as technology advances, as the practices surrounding medicine advances. And you need this rapid generation, collation, analysis, as well as dissemination of data to keep pace with these changes. So the data that's developed, the evidence that is developed a couple of years back, may no longer hold good at this point of time. Might have changed. That's how rapid things are changing. And so you need the ability, healthcare practitioners need the ability to understand the data that is there, to know and figure out if that data is reliable, is it valid, is it something that can be trusted? And then to look at the interpretations around that as the information is shared, and then to take that out and then say, well, can I then apply those interpretations to the population that I see? For the individual practitioner, that translates essentially to a question: who do I treat? Do I treat the patient? Do I treat the sign? Do I treat the symptom? Where do I place data? Where do I place published papers? Where do I place evidence within this entire context? That's a question that we need to think about, and that's a question that must be dissected and must be discussed from the undergraduate level. It's something that every medical student, whether you're at an undergraduate level or a postgraduate level, must understand, and must be able to evaluate for themselves. If they have to keep pace with the rapid changes that are happening in healthcare. And when I say keep pace with the rapid changes that are happening in healthcare, it means keep pace in a meaningful way, understanding what is happening, understanding the essence of what you have to apply. So that's a necessary skill set, an increasingly necessary skill set, as there is a proliferation of diagnostic modalities, therapeutic interventions, and improved understanding of the pathophysiology of diseases, and improved understanding of the molecular basis, the genetic basis, environmental aspects, a whole set of information that has to be collected, collated, analyzed, and then placed in the context of an individual within a society, within a population. That is a skill set that medical practitioners must have, must develop, if they want to keep themselves at par with the advancements that happen in healthcare. Not a second-hand information of handouts, where someone just tells you that, well, this is the way it is, this is my experience, go ahead and do like this. Well, that doesn't need too much of this, that doesn't need too much thought. You take it, you apply it, but you face the consequences if something doesn't happen the way it's supposed to happen. That's not what medical practice is about. So you would like essentially that everyone has the ability to critically evaluate the signs that they see within the population parameters and within the populations and clientele that they see, and see how it applies. So we have that as an integral part of healthcare. We have the interpretation, the development of algorithms, the development of scores that are based on this data. And if we take that path down further, we have the data that determines what sign leads to what's the probability of a person having a particular condition. If they have a particular sign, whether it's a clinical sign, it's an imaging sign, a biochemical marker, whatever that is. And so we have the data that is building towards our understanding of those processes and then giving us a pathway with the hope that those pathways will lead to a more optimal and accurate diagnosis for the person, for an outcome for the person. So you're taking all of this and then finally you're dovetailing it onto a person with a condition who needs a specific care, and then you're using all this data to provide that specific care for that particular person. So to re-emphasize the use of data, the understanding of how data is generated, the understanding of how data is analyzed, the understanding of the interpretation of that data is an essential skill, is a necessity in healthcare practice in these times. That's the whole basis of evidence-based medicine, where you're taking this evidence and then you're applying it. Now then leads to an interesting area. And coming back to the question that I asked, who do you treat? You treat a person, or do you treat a sign, or do you treat a symptom? And where do you place this data in context? Can I take a bit of data, a bit of evidence that I see, apply it on every person and get the same consistent result? Even after applying, even after understanding, critically evaluating, and applying the best quality evidence on a series of patients, will I get widely or slightly different results from each person? Will there be a lack of consistency in the results that I see when I apply the same evidence for the same condition on different people? A question that we must think over when we talk about evidence-based medicine and its application. Do I get the same result if I apply the same evidence on all people with the same condition? Do I get different results? So what are the limitations of the evidence? What are the strengths of the evidence? When I say that I apply evidence, I'm sort of implying that I'm applying the underlying data that has been processed and the interpretations that have come from the processing of that. If the underlying data is not of high quality, the whole pathway is broken. We may not know it, but the whole pathway is then broken. And whatever comes as outcomes is broken, it's chaotic. If the underlying data that builds up this whole pathway is not of high quality. If I do not have all bits of information that are necessary for me to build, which means my underlying documentation also has to be of very high quality and thought through and planned. If I have to make optimal use of this data. Now, even when all of that is of high quality, it's optimal, can I get the same result if I apply a bit of evidence on all patients with the same condition? Can it differ? Can the outcomes differ? Can the progress of the condition differ? Can things differ? And so we see that data is to be placed within the context of a person. And the person is a body with multiple systems, multiple organs that are interlinked and aligned with each other and are working in unison. Some parts of it may disagree with each other, and then you start feeling uncomfortable or not well. But generally, they are working in unison. And there is a mind, and there is a brain. And there's a whole set of things that are working together. And the data has to be placed within that context. And around that person, within that, for that particular person, there's an internal environment and there is an external environment. And the external environment can change factors, influence factors, and the way this particular person reacts at a gross physical level, at a physiological level, at a psychological level, and even at a more subtler level. So you've got the external environment, you've got the internal environment playing together. You've got this physical body with its multiple organs and systems playing together. And then you need to take this bit of evidence and place it within all of that to get a particular outcome. So the point I am leading you to is, even if it is evidence-based medicine, the application of evidence does not recommend the discounting of the information that you gather about the internal and external environment of the person who needs a particular therapy, who is seeking care from for a particular condition. Evidence-based medicine has got a mathematical basis to it, but the maths is to be placed within the context of the person. And so the objective criteria is to be placed within the context of a subjective variation. That's why even if the evidence says that this is 90% of the people will have a good outcome, for the particular person, you might be on, it's 50-50. You might have a good outcome, you might have a poor outcome. It's not really 50-50. Just for the sake of explaining that, I'll put it as 50-50. You might have a good outcome, you might have a poor outcome. You then use the bits of data to see whether you're more likely to have a better outcome. You shift that percentage of good outcomes, the whole probability up, or shift it down based on other factors that go into the building up of that whole algorithm of care. What algorithms of care usually do not include are Other levels, the external environment, the psychological levels, the other levels, parameters are coming. Some of times they are included, sometimes they're not included. So I won't say all the time they're not included. But all of that then comes. And evidence is just one part of that whole picture of care. Think over that. When we say evidence-based medicine, when we say we practice evidence-based medicine, we must be completely comfortable with understanding how that evidence is generated and to be able to critically evaluate that evidence that's generated to make sure, to ensure that they can be appropriately interpreted and applied to the population that we see. We must also be aware and understand the process of how that evidence is shared. What are the parameters to look for when we read that evidence in a published paper? How do you read a published paper? What do you look for? How do you know if this is good quality evidence? How do you know if this is not good quality evidence? How do you develop a clinical practice guideline? How do you use bits of evidence to then inform other clinicians that, well, this can be used and use it this way? What are the processes involved in that? The process of decision making, making decisions, arriving at decisions, clinical decision making, even public health decision making is as important as the process of learning how to actually treat a condition or how to surgically intervene or surgically remove something. That's a thought that I want to leave you with. When we say evidence-based medicine, how are we placing that within the context of care for a particular person? How are we taking that evidence and placing that within the context of care for a particular person to provide the most optimal care for that particular person? What evidence do we need? What evidence do we have? How do we adapt or apply that evidence? We'll talk more about this as we go along. But for now, this is the thought that I want to leave you with. See you again. Take care. Stay safe. Be happy.